Here to introduce our speaker today is Dr. Christy Anderson, our Senior Medical Officer. Christy, take it away.
Thank you. So I'm really excited to introduce our speaker today, Dr. Mayris Weber. She's going to be discussing her work on an important cohort study called the Career Firefighter Cohort. And of course, I'm going to let her go into the specific details or the nuts and bolts, as she put it so eloquently earlier. But I wanted to make sure I emphasize the value of this work in identifying differences in the health of World Trade Center exposed fires compared with other urban firefighters. It's really important stuff. Dr. Weber is a professor in the Department of Epidemiology and Population Health at the Albert Einstein College of Medicine. Her postgraduate degrees in epidemiology include an MPH and a doctorate of public health from Columbia University. She has taught epidemiology and research methods to graduate students, including medical students and practicing physicians at Albert Einstein College of Medicine. In 2007, she started the in-house World Trade Center Epidemiology Research Program at FDNY, serving as its first director. She has authored over 100 peer-reviewed publications, many related to the physical and mental health of firefighters and EMS workers following the World Trade Center disaster. Dr. Weber, welcome. We're looking forward to your presentation.
Great. Thank you so much for the lovely introduction. And thank you for joining me. I'm very happy to talk about the maintenance and extension of a cohort of career firefighters as a non-WTC exposed comparison for the FDNY Firefighter Cohort, which is an ongoing study, and for short, the Career Firefighter Health Study. The background, which you all know, we'll zip through quickly, is that attacks on the World Trade Center on September 11th exposed thousands of workers and residents to vast quantities of dust, smoke, and toxins. FDNY, Fire Department of New York City, was one of the largest groups of affected workers, losing 343 members on 9/11. And since that time, about 200 more have died of WTC-related illnesses. Some FDNY workers were present at the WTC site until July 2002, 10 full months after 9/11. This is just one photo of the air quality that existed around 9/11, actually for months, but of course, in the immediate days after 9/11, looked pretty terrible and actually could be smelled miles away. Let me talk about the FDNY WTC exposed cohort, which consists of about 12,000 firefighters and 3,000 EMS workers. All of these individuals worked for FDNY on 9/11. Now, prior to 9/11, active firefighters and EMS workers received medical monitoring and treatment through an occupational health service at FDNY. Now, the original goal of the occupational health service was duty determination. That is to make sure that if a firefighter or an EMS worker was injured at a previous episode, that they were able to perform their duties. So the primary reason for existence of the occupational health service was to determine if workers were fit to return to the job. On 9/11 itself, treatment for WTC-related injuries began. 3 weeks later, we started a WTC medical monitoring program, and this program included self-administered questionnaires about exposure and current symptoms. Now, exposure was measured and captured by what time people arrived to work at the WTC site, because we know that the exposures were far worse, say, the morning of 9/11, during the collapse of the second tower, and really was pretty rough for the first couple of days until there was rain that damped down some of the persistent fires that occurred. So we use this exposure metric from least exposed to most exposed in most of our studies in one way or another. In 2002, we published the first WTC-related study. In 2006, importantly, WTC-exposed retirees were invited to continue medical monitoring and treatment. This is really important because obviously it wasn't any longer a question of duty determination, but as we know, in terms of following individuals who were exposed, it's really important to follow them after they retire to look for long and short-term health effects. So this was a major breakthrough that we were able to continue monitoring of non-actives or of retired individuals. 2011, as we know, there's a Droga Healthcare Health and Compensation Act was passed, and in 2015, it was reauthorized for 75 years. As part of the WTC health program, medical care specific for WTC-related conditions is provided free. That means without copays for treatment as well as for physician visit. At this point in time, about 3/4 of the WTC firefighter cohort is now retired. So a summary of some of our findings having to do with post 9/11 illnesses. First, a great increase in obstructive airways disease diagnoses. Asthma, chronic bronchitis, COPD, and emphysema are broadly under the category of obstructive airways disease. Increases in gastroesophageal reflux disease or GERD. Increases in upper respiratory diseases, rhinosinusitis. Increase in some cancers, prostate and thyroid, and an increased prevalence of certain cancer precursor cells. Some autoimmune diseases, especially sarcoidosis, have increased incidence. Sleep disturbance is more frequently reported. Loss of pulmonary function, both immediately post 9/11 and over the decades since, has been noted. Many of our findings were later confirmed in other WTC-exposed worker cohorts, and these analyses were mostly internal analyses. So looking at post 9/11 incidents of certain diseases, say asthma, in those who arrived at the World Trade Center to work the morning of 9/11 versus those who arrived, say, 2 weeks later. Firefighting has long been associated with health risks because of the potential for inhalation and contact exposures. Thus, firefighting exposures outside of work at the WTC site may confound studies of the association between WTC exposure and disease outcomes. On the other hand, firefighters, both FDNY and others, meet stringent physical and mental health requirements pre-hire, which is called the healthy worker effect. And because they're extraordinarily healthy in general, this may depress disease rates and make it look as though diseases are less common in certain groups, like healthy workers. The most critical question remains: to what extent are apparent disease excesses associated with WT exposure versus associated with other occupational exposures versus associated with unrelated factors, behavioral factors, perhaps like smoking? The lack of a suitable comparison population has made these questions challenging. We identified a NIOSH assembled cohort of about 30,000 urban firefighters from Chicago, Philadelphia, and San Francisco who did not respond to the World Trade Center attacks. This cohort was originally designed to study cancer and mortality, covering the decades from 1950 to 2009 in firefighters. The PIs, Doug Daniels and Dr. Travis Kubali, supported additional follow-up of this cohort. At the start of the current study then, which is 2016, we included the FDNY firefighter cohort as a fourth site and changed the study name to the Career Firefighter Health Study. All of the analyses that I'm going to show you later in the presentation are limited to firefighters who were active on 9/11, both the FDNY cohort and the non-exposed cohort. So the purpose of the firefighter cohorts in the CFHS, Career Firefighter Health Study, is one, to compare cancer incidence in WTC exposed versus non-exposed via state cancer registry data, to look for a WTC effect. 2, a comparison of the self-reported prevalence of physical and mental health conditions in WTC exposed versus non-exposed to look for a WTC effect. And then 3, comparison of each cohort to demographically similar US populations, SEER 21 for cancer incidence, and the National Health Interview Survey, NHIS, for the prevalence of chronic diseases, to assess a firefighting effect with and without WTC exposure. So after getting funded and after getting our initial IRB approvals, we began focused outreach to leaders from the original cities. The original cities were San Francisco, Chicago, and Philadelphia. Dr. Prezant and the team recontacted the fire chiefs, the commissioners, the union leaders who had already provided letters of support for the grant. We described the study goals, which we had already described, but now in some detail, since we received funding. And we described the goals of extending cancer analysis to 2016. The previous analysis had ended at 2009, and to identify survivors of the original cohort for follow-up. We set up stakeholder meetings to reiterate the goals, to hear concerns, and invited interested individuals to join the advisory committee. We convened the first formal advisory committee conference call on November 8th, 2018. Here are the close to original aims from the grant that was originally funded. Aim 1, determine whether firefighters in the FDNY firefighter cohort have higher cancer incidence rates than non-FDNY firefighters. 2, establish a surviving group of non-FDNY firefighters from the original NIOSH cohort for lifelong follow-up. And 3, compare the post-9/11 prevalence and incidence, self-reported, of physical and mental health symptoms and diagnoses in WTC exposed and non-WTC exposed firefighters. So aim 1 was the cancer incidence in the 2 groups. What did we do to get to where we needed to be? Step 1 was IRB approvals, of course, from Montefiore Medical Center, Albert Einstein College of Medicine, the primary study IRB, from NIOSH, and from RTI International. RTI, I assume most of you know, is a nonprofit research institute. We subcontracted them for contact tracing and outreach to survivors. Step 2, we completed DUA, data use agreements, which did require legal approval. So we had the data use agreements with RTI, with NIOSH, and with the city of Philadelphia. It was quite labor intensive, and also finding the right people and the right lawyers to deal with was not straightforward. But ultimately, we prevailed. We obtained, after getting the approvals, the roster for nearly 30,000 non-WTC exposed firefighters from the original NIOSH cohort. Available information, roster information included Social Security numbers, date of birth, race, and sex. So aim 1 then, based on current and former home addresses, the original NIOSH cohort was linked to 10 state cancer registries, and that covered 97% of the cohort. Similarly, the FDNY cohort was linked to 9 state cancer registries, that covered 98% of the cohort. The IRB state cancer registry submissions started in August 2017, but we didn't file the last one until 2019. One site was unable to accept applications for a full 18 months. And when they were able to accept applications, there was a long queue. So in the end, we received the data and of course the approvals after 34 months or nearly 3 years from the time that we first applied. So comparisons for the cancer analyses, the non-WTC exposed firefighters from the Career Firefighter Health Study. Since firefighters met similar hiring requirements, we partially control for the healthy worker effect and can assess a WTC effect. Each cohort, FDNY and other non-FDNY, was also compared with SEER 21. SEER 21, I assume you all know, Surveillance Epidemiology and End Results Program, gives population-based cancer rates and offer context for CFHS rates. They cannot account, of course, for the healthy worker effect and or different risk behaviors like lower smoking in some groups, which we did find in both firefighter groups. We also linked with the National Death Index and with the Social Security Administrative Limited Access Death Master File. So we matched with these databases in order to get mortality information, to calculate the correct amount of follow-up time and to know when to stop for cancer rates, to limit contact tracing efforts and expense for survey completion, and for a mortality analysis of WTC exposed versus non-exposed firefighters and data which I'll show you a little later on. So what are the characteristics of the WTC exposed compared with the non-exposed males? And we used males in all of our analyses, and the next slide will show you why. But here we look at WTC exposed males in the first column and non-WTC exposed males in the other column. You can see that we have 10,700 and some WTC exposed males and 8,800 and some non-exposed. The average age is a little older in the non-exposed group. FDNY, the exposed group, is whiter and more likely to report never smoking than the non-FDNY, non-exposed group. This is unfortunately what our females look like. We had on 9/11, 28 active firefighter females from FDNY, and there are 585 from the other groups. But because we have so few from FDNY, we're really unable to say much about them. So moving on. The first slide that I'll show you are adjusted relative rates of cancers. So these are males, and we looked at WTC exposed male firefighters versus the non-exposed firefighters. And we saw that all cancer sites, that's all sites together, in the adjusted relative rates, there was a 13% increase. In prostate cancer, there was a 39% increase. Thyroid cancer was also significantly increased in the FDNY WTC exposed. Now, this is a bit busy, but you can see that in the left column are the WTC exposed firefighters versus SEER 21, where the population-based rates. And then in the right column are the non-exposed, the career firefighters from Chicago, from Philadelphia and San Francisco, also versus demographically similar males in the SEER 21. So if we look at the WTC exposed, we see all cancer sites is 1.115, the SIR. Prostate, we see 1.70. We see lung cancer is significantly reduced over the population, and non-Hodgkin's lymphoma is increased, as is melanoma and thyroid cancers. In the non-WTC exposed group, we see statistically significant increase in prostate cancer, statistically significant decrease in lung cancer, increase in melanoma. So WTC exposed FDNY firefighters had a higher than expected number of all cancers together diagnosed between 9/11 and 2016 when compared with demographically similar US males. Rates of all cancer sites together in non-WTC exposed firefighters were at expectation. I want to show you some data from a mortality study that we collaborated on, which received separate funding. So the goal and the major question for this mortality study was, are observed deaths in each firefighter cohort, WT exposed and non-exposed, different from the number expected based on demographic specific US mortality rates? So between 9/12/01 and 12/31/16, there were 261 deaths among WTC exposed firefighters and 605 among the non-exposed. Both firefighter cohorts had lower than expected all-cause mortality when compared with US males. WTC exposed firefighters had lower rates of mortality from all causes and also cancer, heart disease, and respiratory disease mortality lower than firefighters in the comparison cohort. All-cause mortality was far lower in the WTC exposed FDNY firefighters, which may suggest not just a healthy worker effect, but other factors such as full and free access to healthcare monitoring and treatment as part of the WTC health program. Aim 2 was to establish a group of non-FDNY firefighters from the original cohort for lifelong follow-up. We performed matches, as we said earlier, with the Social Security Death Index and the National Death Index to identify a group for outreach, which ultimately consisted of 14,566 firefighters, or slightly under half of the original cohort. This file of survivors was sent to RTI for study recruitment, including survey completion. So this shows you from where we started with the 29,000 or where NIOSH started, let me correct that, 29,992 urban firefighters from the 3 cities. And we took out 12,000 who retired before 1986, believing that we would have a difficulty locating them and it would be more cost effective not to include them. So that left a sample of 17,464 that were hired on 1/1 from 1/1/1987 on, and we sent that to NDI for linkage. So NDI identified in that group 2,831 deaths. Therefore, that left 14,633 not known to be dead. And then we linked again with the Social Security Death Index, and they found another 67 deaths. So the final outreach cohort that we sent to RTI was for 14,566 firefighters. So what were the steps that RTI took before we started enrollment? Contact information was outdated for most of the 14,566 surviving firefighters. RTI conducted batch tracing at 2 time points using specialized vendors to update home addresses, telephone numbers, and email addresses. Contact information was continuously updated throughout the study. We did ultimately end up with updated contact information for 98%, although even the updated information was not always correct. RTI sent out and tracked mailings and phone messages. We measured response to each outreach measure by assessing the number who took the survey within 1 week of the modality, be it an email invitation, a letter invitation, or a postcard. Postcard responses, which we'll show you, are not typical postcards, but the postcard response rate was highest, and so we modified future mailings accordingly. We maintain QA with RTI through regular conference calls, sometimes weekly, sometimes just via emails to track progress. Once data collection started, meaning the web-based surveys were active and available, we actively monitored production levels, which included the distribution of cases who started, completed, and refused to take the survey. And regular reports by RTI were given to us weekly by city. This is, I know, don't try and read it, but this is a typical Excel file that RTI would share with us. And so we could keep track of when the first letters were sent out, when the second were sent out. Now you can see that San Francisco was started months before Philadelphia, and Philadelphia in turn was started months before Chicago. We'll hear about that a little bit later, but this gave us, in a quick and dirty way, a way to see what was going on in each city and to discuss if we felt other measures were needed. What were the FDNY steps before enrollment? First of all, we developed the lingo for the invitation letters that were signed by the IAFF president, which is the International Association of Firefighters, by the chief or commissioner of each city, by the labor leader from each site. We developed the postcards and we developed phone messages that were to be left on people's answering machines. All outreach materials contained a unique study ID and a link to the web-based survey. The chiefs, commissioners, and labor leaders were asked to and did record recruitment videos, which were linked in letters and emails to recruits. And we staggered outreach by readiness of the city. Here's what the postcards looked like. So when I said it wasn't a typical postcard, it was a card that we put in an oversized envelope, which was very beautiful and colorful and was unique to each city. So in the upper left, you see a building. It's a very San Francisco looking building, and it is geared toward the San Francisco Fire Department. And it says online survey. To complete the survey online, visit www.careerfirefighterhealthstudy.org and enter your username and password. That was pre-filled on all of the information that we sent to the firefighters. And it says at the bottom, the Career Firefighter Health Study will take approximately 20 to 30 minutes to complete. You can stop and go back to complete if necessary. Now, in the bottom left, you also see that is a San Francisco specific fire truck. It says again, privacy, all information will be kept strictly confidential. Individual results will not be shared with anyone outside the research team. Results will not be shared with any fire department, pension department, or health insurance company / network. In the upper right, you can see on the back of the gear that this is Chicago Fire Department, and the words are very similar. Please complete your Career Firefighter Health Study survey today. We need your help, and the findings from the study will guide health policy for current and future firefighters in your city and around the country. Because the work is so important, we're proud to tell you that it is supported by the Chicago Fire Department, the Chicago Firefighter Local Number 2, and the International Association of Firefighters, as well as the Fire Department of the City of New York, World Trade Center Data Team, and the National Institute for Occupational Safety and Health. And the bottom right, the information is basically the same, but that is a Philadelphia truck. Now, I won't play the videos for you, but we did give bullet points to each of the individuals. Heather Buren from San Francisco, Harold Schaffberger from IAFF, International Association of Firefighters, and Captain Jerry Cox from the Philadelphia Local 22. And so if you were to listen to them, they gave a pitch to please do your share and help us understand more about health conditions in firefighters. Survey development. We did FDNY, we did the survey development because we wanted the survey to be similar to the FDNY monitoring survey. So the CFHS surveys cover demographics, symptoms, doctor diagnosis. For example, were you ever diagnosed with asthma? And if yes, how old were you when you were first diagnosed? Work exposures, tobacco and alcohol use. Some questions were designed to be similar to the NHIS questions for a population comparison. This was true both in the FDNY survey and in the CFHS non-WTC-exposed survey. FDNY programmed the survey for internet use and developed the interface so RTI staff could access the data. That's how they knew how many completes they had and how many were started but not finished. It took 10 months to program and fully deploy the web-based survey. 90% of surveys were completed on this platform. The other 10% were completed when individuals preferred that it be administered over the phone, which RTI did. And we found that on average, the surveys took about 35 minutes to complete, and participants were paid $10. Let me show you what the front page of the Career Firefighter Health Studies survey looked like. It says, welcome to the Career Firefighter Health Study. You're one of thousands of firefighters being asked to complete this survey, which collects personal and health information about cancer and other medical conditions that affect firefighters' health and safety. The study is intended to guide health policy for present and future firefighters in your city and around the country. It is supported by the National Institute for Occupational Safety and Health, labor union and management officials from your city, and the International Association of Firefighters. Then you had to put in the participant ID that you've been sent, the access code that you were sent, acknowledge that you're not a robot. But let me also show you at the very bottom, there's an 800 number for technical assistance. So any place in the survey, people could call the 800 number. It was not staffed 24/7, but it was staffed every day for a chunk of hours. And if they left a message on the 800 number outside of the hours that it was staffed, they were called back to help them finish or get through the survey, or to offer to administer the survey by phone. So AIM 2, we had about 5,000 firefighters who enrolled in the follow-up study, which was 34% of those we assumed to be alive. San Francisco did the best. They started the earliest. They were the most gung-ho, and they had 43% who completed the survey. Philadelphia was next. They started a couple of months later, and they completed 34% of individuals who were recruited completed the survey. And Chicago started last, and 30.7% of those eligible completed the survey. Let me show you what the non-respondents versus the respondents look like for survey completers. So non-respondents and respondents were overwhelmingly male. We did find that the mean age for non-respondents was a little bit younger, but basically these groups are quite similar. And we did not feel that they were likely to not represent. The respondents were likely to represent, in fact, the cohorts that they came from. Whoops, sorry about that. Okay. So AIM 3, I'm going to show you a little data comparing the post 9/11 prevalence and incidence of physical and mental health symptoms and diagnoses in WTC exposed and non-exposed firefighters. So let me show you some analyses today. In one, we selected mental health outcomes by WTC exposure status using validated screening instruments. So we looked at the PCL for probable PTSD, that's screener, not a diagnosis. We use the CESD for probable depression, again, a screener. And then we use the CFI for a change in cognition. And the CFI, I'm assuming you are a little bit less familiar with that. It measured whether participants felt that they experienced cognitive or functional decline over the past year. And so we gave them specific abilities and asked whether they felt that there had been a decline compared to a year ago. And the second study that I'll show you is a comparison of the frequency of doctor-reported obstructive airways disease by WTC exposure status. And that the obstructive airways diseases are asthma, COPD, emphysema, and chronic bronchitis. So looking at the WTC exposed participants and the non-exposed participants active on 9/11. So you can see that the mean age of the non-exposed is a little bit older. But what I circled here and I found truly remarkable was that we asked if they had a medical visit within the last 2 years, and over 90% of both WTC exposed and non-exposed reported that they had a medical visit within the last 2 years. Obviously, we knew that it would be important if we were asking for doctor-diagnosed conditions that people keep up with their medical visits. So in sum, the follow-up cohort, we found that the non-WTC exposed were older, less likely to be white, more likely to report ever smoking, and less likely to hold a bachelor's degree compared with FDNY WTC exposed participants, but that in both groups, more than 90% reported a doctor visit in the last 2 years. So let's look at the mental health conditions. The mean symptom scores for PTSD using the PCL-17 varied considerably by site, but all were well below the 44 cut point for probable PTSD. Mean depressive symptom scores also varied considerably by site, but also were well below the 16 or greater cut point for probable depression. Now, in terms of CFI, the subjective cognitive index that we use, WTC exposure was associated with fewer subjective cognitive concerns. And of course, this is controlling for age and other covariates. Across cohorts, we found that older age was associated with more cognitive concerns, but fewer PTSD and depressive symptoms. Now, unfortunately, we were unable to look at the association between WTC exposure and PTSD symptoms or depressive symptoms because the non-exposed sites varied greatly in their mean scores, and we did not feel that we could therefore combine the non-WTC sites. And for that, we need longitudinal follow-up in order to be able to assess PTSD, depression, and cognitive function trajectories in firefighters as they age. So this is what the screen for PTSD looked like, or one screen, I should say, for individuals taking the web-based survey. So it says right up top, category PTSD in the past month. Have you been feeling distant or cut off from other people? And then you have the option of not at all, little bit, moderately, quite a bit, and extremely. And these are all questions directly from the PCL-17. If you look at the bottom, you can see that people can save and exit. They can return to a previous screen. And importantly, technical assistance and the 800 number is available to them. Let's look at obstructive airways disease in WTC exposed versus non-exposed. Now, these are the self-reported diagnoses from the surveys in both cases, the FDNY WTC exposed and the non-exposed. We found that the odds of any OAD and asthma diagnoses were 4.4 and 6.2 times greater in WTC exposed compared with non-exposed firefighters. Compared with the general population, that's using the NHIS data, WTC exposed firefighters had greater odds of asthma, while non-exposed had lower odds. And while asthma and other OAD are known occupational hazards of firefighting, WTC exposure significantly compounded these adverse respiratory effects. So let's look at the data. I think this is interesting. So the first column of all firefighters, that combines both the WTC exposed and the non-exposed. And we see that for all OAD, it's 5.4 times the odds ratio. For asthma, it's 3.1, which we see is all WTC exposed essentially. And emphysema COPD bronchitis is over 10 times as frequent in all firefighters as the general demographically similar population. WTC exposed, you see, is 7.7 for all, 4.26 for asthma, and 15.3 for emphysema COPD bronchitis, self-reported physician diagnoses. And in the non-exposed non-exposed versus the NHIS, all OAD is 1.7%, 1.7 times higher. Asthma is lower, which we think is because in most instances, I think all perhaps, firefighters are not hired if they have a history of asthma. And we had a lot of post 9/11 onset of asthma in FDNY, and other firefighter groups did not. This is our guess. Emphysema COPD we see is 3.48 in the non-exposed versus the similar, demographically similar population. Here is what lower respiratory symptoms and conditions looks like on the survey that firefighters filled out. Has a doctor or other health professional ever told you that you had any of the following problems? No, sarcoidosis, and then you just skip right out. We don't ask any additional questions. But if you say yes to sarcoidosis or pneumonia or emphysema, COPD, bronchitis, asthma, RADS, then you get follow-up questions, including how old were you when you were first diagnosed? And again, you see the technical assistance at the bottom of the screen. So where do we go next? What are our future studies? Well, we're looking at diagnoses of asthma in relation to obstructive sleep apnea in firefighters, both exposed and non-exposed. We're looking at the prevalence of cardiovascular disease outcomes, myocardial infarction or stroke in firefighters, WTC exposed and not. Upper respiratory conditions and sinus surgery in firefighters. And finally, health conditions in female versus male firefighters are all on the agenda. I will give you a quick 2 lessons learned, and we learned a lot more than 2, but 2 important ones were unanticipated delays with state cancer registries due to staffing cutbacks pre-COVID. Similarly, there were delays with NDI and the Social Security Death Index matching. So our original goal was to start preliminary cancer analyses in year 2. And as you saw, it took a full 3 years before we had the data. So we flipped the emphasis. We never intended to just do one thing at a time, but we really started to emphasize acceleration on work on AIM 2. Identification and outreach to the follow-up cohort. Problem 2 was we had unanticipated delays in making connections with city leaders due to personnel changes. So in the years since the original cohort, the non-FDNY original cohort was formed, there was complete change in personnel between chiefs, commissioners, management, labor, and the legal departments. And we also found that some cities were ready much sooner than others. Specifically, San Francisco was ready and raring to go, and the other cities we were not yet able to move forward. So it had not been our original goal to stagger enrollment, but we decided not to lose the opportunity to take advantage of the eagerness of San Francisco. So we flipped that and we decided to enroll one city at a time as soon as they became ready to move ahead. And so San Francisco was the first, and ultimately they did the best in terms of enrollment. I'd like to acknowledge what we all know, personal connections matter. We're very, very grateful to David Plazan, to Doug Daniels, to Travis Kubali, and the IAFF leadership who were instrumental in facilitating the study goals. and to my worthy colleagues at FDNY, Rachel Zygowens and Cora Singh, Joe K. Salako, Charles Hall, Alexandra Muller, and to Harold Schaffberger, IAFF President, Pat Morrison, Suzanne Triplett from RTI, who is our primary contact person, to the commissioners and department chiefs and union reps who all helped gain enthusiasm for the project. Here are 3 things that have already been published and 2 other manuscripts that are very close to final on all-cause mortality and obstructive airways disease. Some of the data that I was honored to show you today, and I thank you very much for your kind attention.